right. Good afternoon, APIC Great Lakes members and those outside of our chapter joining us today. Thank you for making the time. The Association for Professionals in Infection Control and Epidemiology Great Lakes chapter is very pleased to welcome you all back to another educational webinars. And for those of us joining us for the first time today. My name is Chao Wen, and I'm joined today by my colleague, Kelsey Ostergren, along with Denise Parr, who is unable to join us today. We are the education team for APIC Great Lakes and have had the pleasure of collaborating with Cincy Dover and Jessica Kirkpatrick from Henry Ford Health to put on today's event, which is titled SSI Surveillance in Ambulatory Care. So to ensure we can all benefit from this webinar, please keep your line on mute and not hold. Hold may play a message or music disrupting the webinar. If you have any question during the presentation, please drop it in the chat so that we may ensure your question is brought forward during the Q&A portion of the webinar. This webinar does not meet the continuing education requirements. However, today's presentation will be recorded and slides will be made available post-webinar. And with that, I would like to introduce our speakers today. So Jessica Kirkpatrick received her Bachelor of Science from the University of Michigan. Upon graduating, she worked as a med tech while continuing her educational pursuits, obtaining her master's in public health. Jessica has worked within the Henry Ford Health system as an infection preventionist since early 2017, becoming certified in infection control in 2019. Jessica spent over 5 years working at the Henry Ford Health Detroit Hospital. There, she partnered with the medical and cardiovascular ICUs, while also concentrating on CLABSI prevention efforts. In 2022, Jessica transitioned to the Henry Ford Health Ambulatory Infection Prevention and Control team to continue expanding her breadth of knowledge within the infection prevention world. While the day-to-day of an acute care IP can vastly differ from that of an ambulatory IP, Jessica has learned that the ultimate goal remains the same: improving and protecting patient safety. Our second speaker is Cincy Dover. Cincy Dover received her Bachelor of Science in Biomedical Diagnostics and Therapeutic Sciences from Oakland University. She is a board-certified medical laboratory scientist and holds a qualification in laboratory safety. After her laboratory internship, she worked as a medical technologist and lab safety coordinator. She began her work as an infection preventionist in 2016 at an acute care facility. During that time, she obtained her master's degree in healthcare administration and became certified in infection control both in 2018. Cincy joined the Henry Ford Health Ambulatory Infection Prevention and Control team in 2019 as an infection prevention specialist. She enjoys the ever-changing experiences and unique challenges that the ambulatory world provides. And with that, Cincy and Jessica, welcome. We are so pleased to have you guys here today, and the floor is all yours.
Thank you.
I just stopped sharing, so you can take over the screen.
Thank you. Okay, can you see my screen?
Yes, we can.
Okay, perfect. So thank you for those wonderful introductions. My name is Cincy Dover, and I have my colleague Jessica Kirkpatrick with me today, and we're very excited to talk to you about ambulatory SSI surveillance. Okay, so just a quick outline of what our presentation is going to look like. So we're going to go through what Henry Ford Health looks like, our background, a little introduction. We'll go through our ambulatory surgery center setup. We will review the surveillance definitions. We'll go through our monitored procedures and how we kind of came upon those monitored procedures. We'll go through the OPC SSI definition and the major differences between the OPC SSI definition and the inpatient SSI definition that I'm sure a lot of you are already familiar with. We'll talk about the IP time that our team dedicates to looking at surveillance, our process. We have a little case study for you, probably something you haven't seen before. We'll talk about some data sharing, the impact that SSI surveillance has made on our team. We'll go through opportunities and goals for the future, and I have a quick wrap up and some resources for you. Okay, so as far as our background, we are part of Henry Ford Health, which has about 33,000 employees system-wide. So Henry Ford Health consists of 5 acute care hospitals, and we have a behavioral health hospital as well. There is a very large ambulatory footprint. So our ambulatory footprint consists of about 150 buildings. We have over 1,000 clinics system-wide, and that includes procedural areas. We have 7 ambulatory surgery centers. We have 5 freestanding EDs. We have dialysis, home care. We even have some retail spaces, such as you might have heard of Optimize. And we also have a Henry Ford provider network, and so this is consisting of affiliated private providers. So our Henry Ford ambulatory team is divided among 6 operating units. You can kind of see there on the side of the screen a little depiction of the kind of breakdown of the units. So there are 3 different markets. We have the central market, and you'll see, sorry, I'm trying to move my screen, the northern market, the southern market. And then we have our team, which was formed in 2019. Sorry, I'm trying to get this out of my screen here. Sorry, technical difficulties. Okay, apologies. So we have our ambulatory infection control team that was formed in fall of 2019. So our team consists of an IP manager, and we have 4 infection prevention specialists. And we kind of have divvied up our responsibilities throughout the regions. So we cover about 65 to 70% of the Henry Ford Health ambulatory sites at this time. Okay, so here's a little depiction of our ASC footprint. So we have of our hospitals we have in our network. So we have 3 hospitals that have kind of their own ASCs affiliated with them under their CCN. So we have Henry Ford Wyandotte Hospital that has Brownstown ASC. We have Henry Ford Hospital, which are the ones that we cover. So we have Cottage Medical Center, Lakeside, Fairlane, which is in Dearborn, Royal Oak Medical Center, and Plymouth Medical Center, which just opened. Those are our newest ones. So Royal Oak opened in 2021, and we have Plymouth that opened in 2023. And then we have Henry Ford Jackson Hospital on the west side of the state that also has an affiliated ASC. We just refer to it as Jackson. Okay, so just a quick introduction for our ASCs. So many hospitals are expanding their ambulatory footprint. So we are increasing, I'm sorry, I'm having more technical difficulties here. So they're expanding their ambulatory footprint. So this is increasing revenue, and we're decanting minimally invasive procedures to ambulatory surgery centers. So major regulatory focuses are, we're looking at the higher complex procedures that are now performed outside of a hospital. So those procedures could be like the hip and knee replacements, but there are such a wide variety of procedures that they're performing in these ASCs now. So not all the same procedures are performed at all ASCs, even within our own system. You'll see maybe cataracts are mostly done at one facility, and then you have one facility that may specialize in hip and knee procedures or other ortho procedures. Maybe you'll have one that does specialties in like breast procedures. So again, not all created equally. Health system ASCs often roll up to hospitals, as I kind of showed you in our little infographic, and the leadership is often shared. So it rolls up often to the hospital system. Okay, so outpatient SSI surveillance has many components to it. So we have the auditing processes, so things like the surgical scrub process, the skin prep auditing, the team members adhering to aseptic technique, environment of care auditing, sterile processing department audits. There are increasing regulatory requirements from surveyors. So the SSI data is shared with our state CMS, and those are called the freestanding outpatient facility surveyors you may be familiar with if you have an ASC. For outpatient surveillance, we had to create a modified outpatient RCA tool to kind of mold it to the differences in the ambulatory centers from the inpatient tools. We have, again, more complex cases moving to ASCs, like I said, hip and knee replacements. You may have spinal fusions. You need to choose what cases to perform surveillance on. So because there are so many cases, you need to look at your high volume cases, and not all of them may be NHSN reportable. And just as an FYI, private providers often lease OR time. So if you're going in to start doing surveillance at your ASC, you need to maybe looking at that. Do you want to have a system with those private providers? You want to implement a system to have them maybe use a fax back form to be able to report SSIs to them as well. Lots of things to think about. Okay, so SSI surveillance of ASCs is a large focus for regulatory bodies. It is not required to be reported to NHSN in Michigan at this time. In fact, our system does not report to NHSN for our ASCs at this time. However, it is required in several states. And like I said, the FSOF, or the freestanding outpatient facility, or state CMS surveyors, are requiring ASC surveillance of some form. Must use the outpatient SSI module for NHSN if you are going to be reporting to NHSN using that OPC SSI tool. So that stands for Outpatient Procedure Component Surgical Site Infection. So this is a different infection definition than your inpatient SSI surveillance. And there is a link included there for you to get to that definition. You can review it yourselves. This is not reportable unless your facility is enrolled. And this gets a little bit tricky. So like I said, like our own ASCs, we are kind of under the hospital's umbrella. So we do not have our own separate CCN for our ASCs. So if you are going to be reporting to NHSN, you're going to need your own CCN specific to your facility. Okay. So SSI or OPC SSI reporting requirements are based on the NHSN operative procedure categories that are found in Table 1, which we'll go through briefly on the next slide. The CPT codes are also required for reporting, and I included a link there so you can review the CPT codes and code descriptions if you're interested. As far as what type of facility can report their OPC SSI data to NHSN, NHSN says that any ASC, as defined by the Code of Federal Regulations, and has a C in the third digit of its CCN, is eligible to join NHSN OPC. So these ASCs will use the OPC SSI protocol for SSI surveillance of surgical patients receiving an eligible NHSN outpatient procedure. So here you'll see kind of a snippet of Table 1. So you'll see a lot of procedures here that you're probably familiar with the inpatient SSI definition. So things like breast, colo, let's see, the hips and knees are NHSN reportable. But again, like I said, you're going to see a lot of procedures that are performed in your ASCs that are not on the NHSN Table 1. So the way that you perform surveillance, you might have to be a little bit more creative. Okay, outpatient versus inpatient SSI. So it's the OPC SSI definition specific to ASCs. There are key differences in this definition as opposed to the inpatient definition. First and foremost, the incisional closure method is not part of the OPC SSI surveillance. So therefore, all eligible procedures should be included in the SSI surveillance regardless of closure method. There are also expanded infection definition categories. So you have your probably familiar superficial, deep, and organ space definition under the OPC general. But then we also have another category included in this definition called breast surgery, surgical site infections. And again, we have a breast superficial, a breast deep, and a breast organ space. And the biggest difference between inpatient and outpatient definition is that meeting additional infection criteria that's found in Chapter 17 for that organ space SSI definition is not part of OPC general organ space SSI reporting criteria. So if you have a knee infection or a hip infection from a total replacement surgery, you do not need to go to Chapter 17 and meet the Chapter 17 site-specific definition. It can be called a definition based on just the organ space category. That was a little different for us to wrap our head around in the beginning. Okay, so procedure types and how to decide what you're going to look at. So when our team was formed in 2019, we were kind of starting from square one, looking at all these cases at different sites. We pulled reports from Epic, which is our electronic medical records system, of all the types and numbers of procedures that were performed at each of our locations that we have. So we ended up pulling about 20,000 individual surgical cases, and we based this from July of 2019, which is when our team was formed, and looked at a year's worth of data into July of 2020. And then we compared which procedure CPT codes were already included in that list of NHSM procedures. So we found that not all cases that we decided to review were included in that list, but many, many were. So things like the hips, the knees, if you were doing spinal fusion surgeries, that would be included. But we had so many more minor procedures that we, in the beginning, wanted to look at that were not included in that NHSN definition. We did end up excluding cataract cases. A few of our facilities do tons and tons of cataract cases. So even though the volume was very, very high, we didn't find any SSI cases. And then we therefore determined that it was not high risk to be looking at those cases and really wasn't value add. We did collaborate with our inpatient IP partners for the 2 locations that were not yet part of our ambulatory umbrella. So those were our inpatient colleagues at Henry Ford Jackson and Henry Ford Wyandotte. So we did include data for Brownstown and Jackson ASCs when we determined this. We did compare the data between all of the sites. And then we selected procedures that were the most complex, had large numbers performed, and then those with a previous history of adverse outcomes based on what we've kind of seen just looking at everything in the beginning. And we continue to revise this list of reviewed procedures based on the trends and areas of concern. So here's my little snippet of my sticky note that I like to keep on my desktop when I'm doing my SSI surveillance. So just a quick, the basics that we're looking at, but I'll expand it on the next slide. So what do we monitor at Henry Ford Ambulatory? So here is our list of locations. So the ones that we are looking at, our team specifically, are Cottage, Fairlane, Lakeside, Royal Oak, and Plymouth. And again, our inpatient partners are at Brownstown and Jackson, looking at their ASCs. So as you can see, quite a wide variety of procedures here. So you'll see a mixed bag of things. So at Cottage, we're looking at breast surgeries, looking at ortho surgeries such as total hips and total knees. At Fairlane, we're looking at some minor ortho procedures, some breast procedures. Lakeside, they do a little bit more low complexity procedures. We're looking at some minor ortho cases, hernias. At Royal Oak, they are very, very high in their hip and knee procedures, so we're looking at those very closely there. Plymouth, since they just opened this year, we're still looking at all cases to kind of determine where our surveillance needs to be there and how it could best be utilized. Brownstown, looking at some ortho procedures, and Jackson also looking at ortho and some hernia procedures. And like I said before, this is fluid. So annually, we like to look at this list and kind of determine if we should be going a different route with what procedures we're looking at. If we should add more, maybe some of them are not very much value add to be looking at. Like I said, the cataracts, we aren't really looking at those at this time. So your list changes as your needs change. As far as time that we dedicate to SSI surveillance, it really depends on a number of factors. So how many IPs are dedicated to your SSI surveillance? How large or small is your list of reviewed procedures? And do you have areas of concern? SSI investigation and write-up can take quite a bit of time. You have to sort through documentation if you have readmission hospital stays, you have to be looking at the lab results, imaging. I'm sure you're all familiar with your inpatient SSI reporting. We have found that outpatient documentation definitely not always as thorough as our inpatient reports can be. So that can be kind of time consuming and a bit frustrating sometimes. As far as what our team does, we have 2 IPs, Jessica and myself, that we both complete the SSI surveillance for the ambulatory sites. We average about 1 to 2 hours a week of case review, and we're looking at about 35 cases a week. And when we have cases that require more investigation and write-up, it takes about 2 hours or plus per case, just sifting through all of that information and going through the process that Jessica is about to go through on the next few slides.
Okay, thank you, Cincy. So what we're going to kind of talk about now is an overview of what our actual SSI process looks like. So what does a case review look like? And then once we kind of give a high level overview, we'll actually kind of go through an example case. So the case review really starts by utilizing our electronic medical record. Since you mentioned, we have Epic, and within Epic, there is an infection control kind of module or build that is called Bugsy. We know, I will say this, that we are very lucky to even have the capability to utilize an electronic kind of surveillance program. We know that not every site system has this ability or has this accessible to them, but this is what we have, so we'll kind of go through that process. So within Bugsy, what we did is we went back and forth with our Epic team to really create a SSI report that helped us pull the information we were interested in reviewing or seeing without a lot of extra noise, which did require some back and forth, as mentioned. So one of those, for example, was our report originally included cataract procedures, but that was something that through learning, we realized that added a lot of noise to our report. Most patients come back for the alternative lateralities procedure for cataract management, and therefore they're getting flagged back into a report as having a return to OR within 90 days. And again, as Cincy mentioned, we weren't really finding SSI cases with those. We still want them to be somewhat on our radar, but we created a separate report for them so they wouldn't fill up our report with cases we're actually kind of interested in. So right now, our report is currently pulling all potential signs of infection within 90 days from that original procedure. So that would include readmissions, returns to ORs, any positive micro within 90 days. We know that there are some instances where the surveillance window is only 30 days, but the knowledge or the build capability doesn't allow us to distinguish between what is a 30-day surveillance period versus what is a 90-day surveillance period. So we just have to build everything as a 90-day period. Again, it adds a little bit more work on our review for when we're doing that initial review, but we don't want to miss things. So that is included within 90 days. We're getting our readmissions, return to ORs, and positive micro. And then also, for example, purulence was originally a word that we had flagged to be included within this report. What often we were finding is that the documentation of no purulence was flagging and causing that to show up on our report, when really, again, there was just no purulence. So it wasn't a sign of infection, but was something that ultimately we decided we didn't want to pull into this report. And then as of right now, antibiotic dosing is not currently built into the logic of this report. There's been some issues with the report being able to determine the specific, or being able to pull in the appropriate timed antibiotic. So sometimes it was pulling in kind of the pre-surgical dosing that was done instead of the after surgery dosing. So that's right now not built into our report. Okay, so then once we kind of are doing that initial, we're looking at our Bugsy report, anytime a patient or a surgery pulls up on that report, we're going through those cases. We're going to look to see first, this is pulling up on our report, is this actually a surgery that we're interested in reviewing? If it is, great, like let's start doing some chart review. So within that chart review for each potential case, we are looking at every note, we're looking at all the micro, the labs, the path, we're reviewing imaging, we're reviewing surgical logs of whether it's with what they're being flagged for specifically is also a return to OR, and we're reviewing medications. Cincy did note that the notes are not all created equal, and that is something we have found within doing the outpatient SSI. When a patient is admitted to an inpatient, they're seen by multiple specialists, they're seen multiple times a day, there's great documentation of what's going on with that patient. Maybe great's an exaggeration, but there's pretty thorough documentation. We often find that when we're doing outpatient SSI surveillance, the patient may be seen in the clinic and it is a one-sentence note and very little detail is there. So a lot of chart review time is really spent trying to dig through every potential place we could find information, because it's just not always well grouped together for us, like we would see kind of in inpatient surveillance. So as we have completed our chart review, if there are no signs of infection, then we are able to document that within Bugsy or within Epic Bugsy. And basically we can say very kind of summarize what we were finding within our chart review. So for example, patient had a hematoma, we're not seeing any purulence, they're not meeting the OPC SSI definition. We just kind of put that in there for tracking purposes, and then we can save, and that closes out that case and takes it out of our report. But it does indicate that we have reviewed it, and therefore we're not having to come back to it or duplicate any kind of work. And then if an SSI is identified during our case review, then multiple steps follow that. So we do document on an internal line list. For us, that's an Excel spreadsheet that really aids in data tracking for us if we ever need to kind of create pivot tables or see trends quickly. That allows us to do that. We then document in Epic in the Bugsy component, just like we document if it doesn't meet a case. We have to clearly outline why it does meet definition when it is an SSI. We complete a root cause analysis form or an RCA. And then we also have formal SSI communication or notification that goes to surgical services. Okay. So this is an example of our internal documentation. So for SSI cases, we are tracking key details, as I said, on our internal line list. This is a lot of the column headings that are in our line list. It's not all inclusive because our line list is, I think, like goes to column X, Y. It's like an extensive amount of columns. But this is just an example of some of the information that we internally track. So we are looking at surgeon and OR staff details. Of course, we're looking to see if there's any commonalities, if we have, staff who are frequently within or are present for some of these SSIs. We're looking at procedure details, the type, the length, the wound class, priority, the surgical prep that was done, closure methods, drains, if antibiotics were given pre-surgically. Of course, patient details, age, gender, weight, medical history, surgical history, lowest body temp, glucose level, signs of infection, readmission, return to OR, purulence, positive micro, imaging, all of that kind of fun stuff's in there. And then general case notes, provider notes, details of post-op care. And we really want to include some of that because, again, we may not have all of the flow sheets that are created or filled out when someone's an inpatient, but we need to kind of skim through all those provider notes. And sometimes it's one random provider saying that there was purulence, and they write it in such a kind of roundabout way within the note that we will sometimes copy and paste that directly into our line list, so we can copy and paste that directly into the information we're sending forward to surgical services so they can see exactly how something was described by the provider. And also, just for example, reasons we want to track a lot of this stuff internally is this is a very quick way for us to reference and see trends. So for example, we have a surgeon who really was concerned that her patient population may be relating to or correlating with some of her SSIs and wanted to inquire whether or not she was seeing higher BMIs than other surgeons, or if maybe that was related to some of the SSIs she had had. And that was something, because we had this line list where we're tracking BMIs, we could kind of easily and quickly reference to see, like, is this not the standard, or is this standard and every surgeon's kind of encountering the same thing? But it's really a great centralized place that we always have access to. We always can kind of manipulate with pivot tables to kind of summarize data for ourselves. So although it is a time-consuming process to internally track all of this for ourselves, it really is such a helpful resource to have at the hands of an IP. Okay, so once we have completed our internal line list tracking, then what we want to do is document within Epic or Bugsy. So that is documenting all of the SSI case details and what made it meet NHSN criteria. So Bugsy does some of the linking for us or connecting for us, which is really great. Again, we know we are fortunate to have something like this, a tool like this at our disposal. but it does link the procedure of interest, it does link any positive micro, and it does link the surgeon for that case. So some of it's pre-populated for us, which is great. But then a lot of the information has to be added in by infection prevention in the abstraction form. So that's a screenshot of what our abstraction form looks like in Bugsy for this. So it's wanting you to document what was the specific type of event exactly. So are we looking at a superficial? Are we looking at deep? Are we looking at organ space? That kind of information. When was it detected? What were the signs and symptoms? We're also kind of looking for, was it meeting criteria because of the laboratory testing? So this essentially, our abstraction form takes a lot of the NHSN definition for us and allows us to select what it actually met with, because ultimately, what's so great about this is when or if you end up reporting this information to NHSN, this does that documentation for you, so you can send this information from NHSN. So that's information that's great, but what's interesting, and we'll kind of talk about this later in terms of what we've realized through this process is a gap, is because outpatient SSI surveillance is a relatively new phenomenon in the infection prevention world. These abstraction forms that were built into these kind of EPIC tools or modules to help us really correlate more with inpatient SSI surveillance. So there are some information in here that isn't relevant to us, such as what Chapter 17 definition is this meeting, that we ultimately have to kind of not populate because it's not relevant to us, but the information is all there. Okay, so now at this point, we've done our line list, we have done our Bugsy documentation, and for our next step, we are going to end up filling out a SSI root cause analysis form, or an RCA form. So infection prevention completes the majority of this information. Essentially, we've done all of this chart review when we're filling in our internal line list, when we're documenting in Bugsy. So now we're putting it into another form that is sent to surgical services leadership, is sent to kind of OR managers, so that the hope is we can save some of them some chart review time, since we have already done that by providing a lot of the pertinent details on the case within this form. And then they, of course, always end up usually doing their own chart review to add information to it, dig deeper into things they may be interested in, but a lot of the information is provided for them. So we complete everything that's there kind of in white. And then, slide please, this RCA is sent to the OR manager once we've completed everything in white. It's also going to surgical services leadership, our infection prevention medical director, our quality director, as well as some of our risk colleagues. And the goal is really to gain that insight from our OR managers or staff, while also in a way holding them accountable for the infection. So feedback is requested from the OR manager. We are specifically requesting the information that's in those highlighted fields. That is highlighted for them when we send it to them, and we basically say within the email, there's information that's highlighted on the form. That's what we're specifically looking for your input on. So what we are inquiring about with their help is person performing skin prep. We have found that this is often not consistently documented within the medical record, so they're able to obtain that information for us. Any known problems with maintaining temp humidity in the OR, while we would hope that infection prevention is contacted in the event that something like this does happen, you never know. Things sometimes fall through the cracks. And so we want to know if, say, there was something that occurred that we were unaware of, if there were any known breaches in sterile field or protocol. Again, that's not something that's going to be documented in EPIC. While you would maybe hope it was, you would maybe hope that some sort of back-end kind of filing would have happened. For example, we use something called RLs, where we could kind of track some of those issues on the back end. We have also heard, and I'm assuming this is not something that has just been like we've experienced, we've heard about some kind of interesting things that staff have been like, oh, this person did this, or this person did this, and it's a lot of kind of, hearsay, telephone that has happened. So I think having the OR manager have kind of a safe place, because a lot of people don't find that or think that EPIC might be the safe place to do that, to let us know about something that may have occurred. We want that opportunity provided to them. And then, of course, any technical difficulties during the case. Was there a malfunction in equipment? Did an instrument break? Did anything like that happen? Do we need to know about? And of course, other factors that may have contributed to the infection. And the big one, how could this infection have been prevented? Sometimes we get really insightful information when we get this back from the OR managers. Sometimes we don't, but we kind of always give them the opportunity and hope that they really take the opportunity to provide us with information. And again, this is sent via email electronically to them. And then in addition to that RCA being sent to our leaders, within that same email is also something that's kind of what we consider our SSI notification or our formal notification, which is a letter that is sent to surgical services leadership. And this really, there's an example here, a lot of information that's just kind of like mock information that's put in there. But we outline the SSI definition, specifying why specifically the case that we're sending to them met definition. We kind of took this idea from some of our sister hospitals within the system, where they would send formal notification letters to the surgeons. We, at this point in time, are not sending the notification letters to the surgeons. We have found that often sending this information to the OR managers will talk to the surgeon as they're inquiring about the case, but we at this point in time do not include them in that direct communication.
Okay, thank you very much, Jessica. So I just wanted to provide you with a quick case study, just so you can see some of the changes between the outpatient OPC SSI definition as opposed to the inpatient definition. So I know this is a little wordy, but I'm gonna, this is based on a true case, but the details have been changed here. So this is not all of the accurate information. Okay, so we had a 29-year-old female to male patient that underwent a bilateral mastectomy on 4/3/23. They came to the ER on 4/18 with redness, warmth, and pain to the left surgical side. They had a fever reported of 1 day. They had body aches, nausea, and vomiting. While they were in the ED, the patient had purulence, erythema, warmth, and tenderness at the left chest tissue. They had a fever that was Tmax of 38.4. They were tachycardic into the 140s. They had a high WBC that was 26.1. They had a code sepsis initiated. They were resuscitated in the ED with antibiotics and IV fluid. And the patient was admitted from the ED with a soft tissue infection. So during their hospitalization on 4/19, they had a superficial wound culture that was positive for Corynebacterium, Candida albicans, and Staphylococcus. Also on 4/19, the chest CT revealed, and this came from the physician's documentation, large fluid collection within the bilateral post-mastectomy surgical bed, which extended from the mid-anterior chest, inferiorly, and laterally. Overall, the fluid collection measure was 35 by 9 by 2.5 centimeters, and that fluid collection contained some internal gas, and the fluid appeared complex, suggesting either abscess or infected post-op seroma. On 4/20, they underwent an an ultrasound-guided drain placement into the bilateral subcutaneous chest wall fluid collections, and they had 480 milliliters of purulent-appearing fluid aspirated, and those samples were then sent for culture. Those fluid cultures, unfortunately, resulted back positive for moderate strep pyogenes. ID was consulted during their hospitalization for treatment, and the patient was discharged home on 4/23 with linezolid. So, taking that all in, what did this mean? They were at an outpatient facility. They have this done. So this actually met OPC breast organ space SSI. And that was because within 90 days of the procedure, the patient had purulent drainage from a drain that was placed into the chest wall space, and an organism, which was Streptococcus pyogenes, was identified by culture from an aseptically obtained specimen from the organ space. And the date of event was 4/20/23. Now remember, we don't have to meet that Chapter 17 definition when we call an organ space definition. And below is the infection criteria for OPC breast organ space. So as you can see, we met the following criteria. We had the date of event within 90 days after the NHSN operative procedure. We had an infection that involved any part of the breast deeper than the fascial or muscle layers. So this was the subpectoral, lower than the subpectoral layers that was open or manipulated. And the patient had at least one of the following. So we had purulent drainage from a drain that was placed into the organ space. and we had organisms that were identified from an aseptically obtained fluid or tissue in the organ space by a culture. Okay, so thank you, Cincy, for going over that case review. So that's really just to show you that the complexity of the cases is similar to what you also may see within inpatient SSI surveillance. We're seeing a lot of that in the outpatient world, particularly as more of those complex cases are being decanted into ASCs. It's just kind of highlighting also the importance of this surveillance because we are seeing similarly complex cases, it's really important that we are also doing the surveillance on those cases. So also within that information, or why we're wanting to collect this, is we need to data share what we're finding. We right now are sharing that information, our case counts, with our affiliated hospital infection control committees. So if those ASCs, they report up through one of the hospital CCNs, so we will share that information at that hospital's infection control committee, which usually happens on a monthly basis. And then we also actually have a system ambulatory surgical services meeting where we go through on a monthly basis. We look at cases that happened, including case counts, and kind of have the opportunity to discuss anything there, particularly if we're seeing kind of similarities across sites as well. So here's kind of an overview of what our outpatient SSI data has looked like. We started completing outpatient SSI surveillance in June of 2019. We were originally looking at all cases, and then over time standardized what outpatient cases would be reviewed across the system. So we have had some flexing as we have continued to do this with time. So in 2019, the year this was started, which that information is really only for, or that count is really only for half the year since it was started in June of 2019, we ended up identifying 6 SSIs. At that point in time, we were looking at all cases and we were using the inpatient SSI definition. So we were having to go through and make sure that everything actually met Chapter 17. Because it was new, we were trying to be standard or kind of be standardized with our inpatient IP partners. And so that's why we thought we would kind of go that avenue. But then ultimately, we ended up shifting in 2020. We ended up still looking at all cases, but we started using the OPC SSI definition. In 2020, 10 cases were identified. In 2021, which is when we opened up Royal Oak, we ended up identifying 14 cases. We were looking at all cases still using the OPC SSI definition, but we had an increased volume because we opened up an additional ASC that year. In 2022, we had 7 SSIs identified. We were narrowing down our surveillance, therefore. We weren't looking at all the cases. We were kind of at that point looking at what is our more high-risk cases. And we were then still using the OPC SSI definition. And then in 2023 year to date, which this year at the beginning of the year, we opened up another ASC. We opened up Plymouth ASC. We year to date have identified 8, and we have continued using that narrowed down surveillance list and of course continued using OPC SSI definition. So the reason we want to do this is that doing surveillance has an impact. It really has identified opportunities for improvement for us. We have found areas of concern that would benefit from additional infection control involvement. So for example, a surgeon with a higher SSI rate or particular surgeries that we're seeing have higher SSI rates. So it really brings to our attention something that's almost like, here's our initial kind of red flag, orange flag. Now let's start to dig to see if there's anything else we really need to figure out what's going on here, or is there something we should be concerned about? We've also identified stewardship opportunities in ASCs. So really standardizing or improving the antibiotic use pre or post-op. We were noticing there were some inconsistencies within the ASCs. By having that kind of monthly ASC OR meeting, we're able to talk about that there. We're able to look at our SSI cases and then at that platform kind of talk about, well, we've noticed the dosing for this, or we're noticing this is different here. Like, how can we help standardize this? We're the ones doing the surveillance, finding the opportunities, and then kind of bringing it forward for discussion. And then also the implementation of pre-op decolonization in all of our ASCs. So our inpatient hospitals, we're doing this pre-op decolonization. We have called it, or the Henry Ford Health has called it swipe, swish, swab. So it's the chlorhexidine bath, it's the chlorhexidine mouthwash, and it's also swabbing
with the nose and nasal decolonization. So that was something that was being done at our inpatient hospitals, but it was not something that was being done across all of our ASCs. And this opportunity, when you have data to support why initiatives are important or why bringing on an additional cost could be helpful, it's really critical when you're trying to bring that forward to leadership to ask for additional resources to be provided for patient safety sometimes. So we've mentioned some of this throughout, but of course, with anything, whenever you start something, you're going to find opportunities for improvement or gaps. So right now, I've mentioned we currently don't have direct contact with our surgeons. Our inpatient hospital partners do, but we don't have that direct communication. While our OR managers are often discussing the SSI cases with the surgeons are not directly accountable to respond to our SSI notifications, are not directly or not currently accountable to respond to our RCAs. Also within our gaps, we've noticed that there really isn't a peer review process in our ASCs at this point in time. We have that again for our inpatient hospitals. We don't have an established OR SSI peer review process in ASCs. And then because this isn't a mandated process at this point, no one's required to report this to NHSN. So we've noticed that kind of the next couple bullets that are on here all go into the same point, which is it's really hard to compare data outside of our system, even across facilities within our system, because we don't have an SSI comparison, SIR comparison at this point. We really are utilizing our own rates within here, but we don't have kind of national data to compare to, which sometimes is really what you need to bring forward to a surgeon to highlight to them what opportunities there may be specifically for them, or to provide them with some insight like, hey, this is how you're doing compared to the rest of the country. We don't have that ability right now. And then of course, because this information isn't being currently CMS reported or mandated to be reported to CMS, there isn't a monetary incentive, which we kind of we wish this wasn't the way it is, but sometimes it makes it hard to get buy-in from all the key stakeholders. So many of your leaders only have so much time to give to certain things, and sometimes that time is going to have to be dedicated to the things that are bringing back that monetary reimbursement for them. So without that for us right now, sometimes it's a little more challenging to get the buy-in that we want or the support that we want. And then I mentioned this earlier, but the EPIC tool that we have right now, again, because this is a kind of new to the ambulatory world or new to the infection prevention world, the EPIC tool, we have some of these kind of bigger things that have been built for us are not built for outpatient or OPC SSI at this point in time. So because it's wanting Chapter 17 information right now, which is not applicable to OPC SSI, that information is kind of, it makes it difficult for us to compare data, or would be to compare data if we were sending things off to NHSN. So at some point, we would like to continue to work on modifying things as this continues to be something we do. And then also our goals for the future with this as we continue through this process, increasing our presence in the ASCs, OR observations and audits, kind of continuing to let the surgeons know that we're here, we're continuing to do surveillance in the background, but now we're also kind of present in your ORs watching to see what's going on. Increased RCA involvement, of course, from our surgeons. We would love to have a peer review process that was in place, particularly if there is something that maybe we think might be a little interesting or might need additional eyes on it. It'd be really helpful if we had that peer review process already established that we could fall back on. And then an EPIC tool specific for OPC SSI surveillance, so we could kind of more easily within EPIC compare RCA data, compare SSI reports that way.
Okay, so to wrap up, we have some key takeaways here that we wanted to reiterate. So it is a time-consuming but important process to perform the OPC SSI surveillance. NHSN reporting is not currently mandatory in Michigan, but regulatory bodies are expecting to see surveillance data when they come into your facilities. It's very complicated, so start looking at surveillance now before it does become mandatory. It's very helpful at identifying areas of opportunities and guiding ASC SSI prevention strategies, as Jessica just described. It's very helpful to narrow down your surveillance to areas of concern and your highest volume or highest complexity cases. You very well could struggle to get leadership buy-in since it's unfortunately not tied to reimbursement at this time, but ultimately patient safety is our top priority always. And we've included some resources here that we referenced throughout our presentation. We have the OPC SSI definition, the outpatient procedure component website from CDC, the monthly reporting plan and annual facility survey, and OPC key terms. And if anyone has any questions, I think we have a bit of time left over, but here is also our ambulatory IC contact information. So that first email is our group email. You have my email there. My name is Cincy Dover, and then Jessica Kirkpatrick email is there as well. And that is all we have. So I hope we can take some questions. I see there's a lot of chat things that popped up.
Yes. So first and foremost, Cincy and Jessica, thank you so much for your very thorough presentation. There's been, as you mentioned, a lot of chatter in the chat box and some really high praise for this. So thank you once again for sharing all of your knowledge and information with us today. I think this has been really well received. There have been a number of questions, so we'll kind of start at the top and run through them. If we run out of time, we can follow up offline, but we'll make sure we get all the questions answered here in the chat. So the first question is, can you just revisit the ambulatory surgical center, the CCN piece that you mentioned at the beginning, and sort of how that relates back to that of the parent hospitals?
Yes, so at this time, so the OPC SSI definition requires, if you are going to be reporting to NHSN, your ambulatory surgery center has to have their own unique CCN. So at this time, our facilities are under that hospital umbrella. So our ambulatory facilities, for example, our Grosse Pointe facility, Cottage Medical Center, does not have its own CCN number. So we roll up to the hospital. So that prevents us from really being able to report to NHSN at this time. So does that answer the question?
I think so, but if not, please go ahead and put it. Okay, she says yes, thank you, perfect. Okay, the next question is, does your readmission capture patients with surgery at ASC who were admitted to an acute care hospital?
Yes. Yeah. So we pull in right now any admission. It has to be, unfortunately, at this point in time, an acute care hospital within our system, but 90 days readmission after any procedure is getting pulled back into our report. We have been sometimes notified by, which I think probably a lot of inpatient IPs may have experienced, sometimes you get notified by a different hospital that's outside of your system if they have a patient who had surgery with you admitted to them. So sometimes we have gotten those one-off communications from other hospitals, but our report specifically pulling everything within Henry Ford Health.
Thank you. The next question is, I guess, is sort of more of a comment or a suggestion, but it says, have you considered the questionnaire feature in Epic/Bugsy to capture the extra info instead of creating a manual line list?
So I think we have, but our manual line list at this point is a lot more comprehensive than what our Epic Bugsy build is built to pull. So we're looking for a lot of information that at this point in time isn't an easy abstraction from Epic. For example, when we're copying and pasting from notes, we're just looking for verbiage from a provider, which isn't going to be easily pulled from an Epic kind of auto pull. So we've thought about using Epic as much as we can, but ultimately the line list has been the best way for us to track all the information we want and also to have absolute control over it. Because anytime you want to modify what Epic is pulling for us, it requires some back and forth with our Epic support. And when we want to modify something on our line list, we have the capability to do that ourselves. Also, just for data pulling, like we have found it easier to manipulate our own pivot tables than utilize some of the functions within Epic.
Appreciate that, Jessica. Thank you.
But if there's something out there that you know about the Epic or Bugsy's ability that maybe we're missing, feel free to let us know. Like, we're always welcome for more help.
Yes, and you guys put your contact info right on the slide here, so jot that down if you want to send Cincy or Jessica a note.
You can make our lives, if you make our lives easier, we'll like love you forever.
Yes, we're we're all in favor of stealing and borrowing and using what others have created. So as much as we can do not to duplicate efforts, I think they're better. There was a question if the RCA forms that you guys use are available. And I don't know if this is intent, like the question is, can you share the ones you're using? So I guess Jessica and Cincy, if you have input on that.
I think we can share them. Yeah. If you could drop us an email afterwards, we'd be happy to share.
Awesome. Thank you. The next question is, are you tracking anything related to GI procedures, colonoscopies, endos, etc.?
So we are not at this time. I guess, no, we are not. I guess I'll leave it at that. No.
I will say one of our sister kind of IP areas, they do pull in all their GI procedures to their OPC SSI report. So we have kind of seen how they've handled this. I don't think that's us talking.
Nope, I just muted them. They just came off mute. Okay. So go ahead. Sorry.
Okay. One of our kind of our colleague components, the people who perform our inpatient IP colleagues who perform surveillance at one of our other ASCs, Brownstown, they do review all of that information. I don't think they have not seen kind of alarming rates from it. I think if they notice something super concerning, we would start tracking that ourselves. But we do not do that. One of our other ASCs is tracking that.
Awesome. Thanks, Jessica. And there is one follow-up to the question about admissions within 90 days. So they're asking if all surgeries within 90 days are pulled into that report, do you guys then manually go back through and look at which of those were completed at an ambulatory center?
So our report is built to only pull in procedures that were completed at ASCs. So we get everybody who had a procedure at ASC who was readmitted. The hospital surgeries are not included on our reports.
Okay. Okay. So once you get that report, it's already narrowed down just to the ones that were completed in the ambulatory. Okay. Perfect. Thank you for the clarification.
They have their own separate functions in Bugsy for the inpatient report.
Okay, wonderful. Thank you so much. And I do want to be mindful of time. So Chow, if we can move forward with the slides, I just want to provide a few closing remarks and then we can conclude our call today. So just a couple notes on upcoming events. Our fall education session is October 24th, which is coming up very quickly. And that will be held once again at the Eagle Eye Golf Club in Lansing. And then our last virtual session for the year will be November 28th. And we will be joined by the Joint Commission to talk more about their standards. So we're really looking forward to that session. And then there is contact info at the bottom of the slide for Chow, myself, and Denise. So if you have questions, feel free to reach out to us. I know there was questions in the chat too about the slides and the recording for our session today. All of this, the recording for this session will be posted on our YouTube channel. So if you haven't visited that, check that out. And then also the webinar slides will be posted on our Great Lakes webpage as well. I do want to note for those of you who are joining this call that are not an APIC Great Lakes member, you will not get our follow-up communication for this since we don't have your email address. So either check our YouTube channel so you can find the recording or put your email address in the chat if you want to be included in that, and we are happy to include you in that follow-up email. All right, next slide. Perfect. Thanks, Chow. So this is our job postings. If you have a job posting for an infection preventionist or associated staff, please send them to Rebecca. We're happy to include those in our job board so that we can continue to promote and share openings and try to get those filled. And last but not least, just Cincy, Jessica wanted to thank you and the rest of your team again for all of the information you shared with us. This has been incredibly beneficial. And really just appreciate all 97 folks that logged on to the call today as well. I think this is one of our most highly attended webinars. So thank you all for joining and for participating in the robust discussion. And Cincy, Jessica, once again, thank you so much for being with us today.
Thank you. Thank you.
Thank you.